If you're listening to this, you're probably strongly considering or planning on having breast implants placed for breast augmentation. I just always say that I want my patients to have all their information up front before surgery about breast implants. And I would never want a patient to have an issue come up a few years after surgery and feel like, wow, no one ever told me this could be an issue in the future before I got my breast implants placed. So I'll start by saying that breast implants are FDA approved, safe medical devices, but they are just that, they're medical devices. And while they could last forever, they're not guaranteed to last forever. So when you have them placed, it's sort of a lifelong commitment to a medical device in your body, or for as long as you choose to maintain that medical device in your body. And there are issues that can arise in the future. So I like to reference a couple of pieces of patient education. One of them is a booklet like this from the Mentor Corporation. It has a few diagrams within it that I like to show patients. If you're able to see this one, it shows different places where we can make an incision to place a breast implant. So we could place an incision in the fold under the breast, around the areola, or even in the armpit. My favorite approach to place a breast implant is that incision in the fold under the breast. If you don't need a lift or your nipple and areola moved up in position, I would rather not make a scar on the front of the breast. So I do prefer the fold for that reason. Also, we have some data that suggests we see a lower risk of certain complications when we work through that fold incision rather than through the front of the breast, going through breast tissue. We see a little bit of a lower risk of infections and of a tight scar capsule called a capsular contracture forming in the future. We'll get into details about those risks in just a few minutes. I'm not a big fan of the armpit approach. I think it's a harder technical surgery to get the pocket where you want it to sit. It's also a little bit of a harder recovery for the patient. So this diagram I find to be useful. Hopefully you've each got this booklet. One more diagram in here would be this diagram showing the difference between implants placed over the muscle and under the muscle. There's pros and cons to each of those positions. The disadvantages of going over the muscle tend to be that there is a less thick layer of tissue covering the implant, so it can look a little more ridgy or unnatural through the upper part. Many patients who are undergoing a breast augmentation don't have a lot of tissue in that area to start with. That's why you're getting an augmentation. So it can be a little unnatural looking, and it has a higher risk of showing a ripple or a divot of the implant that can look very strange over time. We also find a higher risk of a capsular contracture or a tight scar capsule forming around the breast implant when it's in the over the muscle position. Under the muscle position, we see a lower risk of capsular contracture over time. Also, radiologists are happy to see implants under muscle when you're old enough to undergo mammograms because they feel confident that they're seeing that breast tissue pushed out in front of the muscle and then the implant, rather than worrying about tissue that's obscured by the implant over the muscle. The main drawback to going under the muscle for most patients would be something called animation deformity. So that means if you stand topless and look at yourself in the mirror, kind of put your hands on your hips and flex your pec muscles, the muscles will do this little twitch maneuver over the implants. That is usually mainly an issue for patients who are professional bodybuilders or competing in fitness competitions wearing small triangular bikinis. If that is your situation, then it's worth talking about these alternatives further. Many of my patients say they're not planning on doing professional bodybuilding, so they're not so concerned about it. In general, I like to go with under the muscle position of the implant rather than over the muscle for all these reasons we've just talked about. So I'm going to have another piece of patient education that I'll reference, and hopefully you've all received also either electronically or in paper. This is something called the Patient Decision Checklist. Around 2020 is when the FDA decided that every major manufacturer of breast implants should have a patient decision checklist that outlines all the major risks associated with breast implants and breast augmentation surgery. So this document starts off pretty broad spectrum and says, hey, you may not be the greatest candidate for breast implant placement if you've got any issues like an untreated infection in your body or a precancer or an untreated cancer within your breast tissue, or if you are actively pregnant or breastfeeding. It then moves on to other conditions that could put you at higher risk of a poor surgical outcome, listing things like diabetes, active nicotine use, or an active smoker, or heavy smoking history in the past. If you're taking drugs that weaken your body's immune system, like steroids, or if you're undergoing chemotherapy or have been through radiation therapy. Also, if you have conditions that interfere with normal blood clotting, or if you have any conditions that reduce the blood supply to your breast tissue. These could all put you at higher risks of complications with breast augmentation surgery. And then finally, there's a paragraph down here that says, we acknowledge that there are certain conditions that have not been adequately studied yet to determine if you're at a higher risk of a poor surgical outcome. And that's things like lupus or early onset rheumatoid arthritis. If you have a history of mental health disorders or body dysmorphic disorder or a severe eating disorder. And then they also say if you have a history of having products permanently implanted into your breast tissue, like prior meshes or free silicone injections. These are some conditions that we don't quite know exactly what your risk is of complications with. We have some concerns that if you have a history of autoimmune disorders, you could be at a higher risk of having poor outcome with breast implant placement. I tell patients if you've got a history of something like lupus and your body is attacking its own tissues, we can't be confident to know how your body is going to respond to a foreign object placed within its tissues. We're going to talk more about that in a few minutes also. The patient decision checklist then gets into more specific complications, and they start with talking about complications that are related to surgeries on the breast. Things like bleeding and infection, which in general are rare, 1% to 2% risk associated with a severe bleeding or infectious complication that could require more surgery. Other things are more common, like breast asymmetry. They say that that can be in up to 12.7% of patients. And during your consultation, we'll assess your breasts to see if one is significantly bigger or smaller than the other. Sometimes one's higher, one's lower. Sometimes the breasts, one's looking out to the side and one's more straight ahead. Those are all little differences that sometimes patients notice more after going through an augmentation. And so it's important to kind of sort those out during your consultation. Sometimes we need to talk about doing a slightly bigger implant on one side than the other to try to make things look more even. Other risks, they talk about unfavorable scar formation, which is pretty rare. If we're doing an augmentation alone, we're creating a very small scar. It's usually less than 4 centimeters in length. And so we usually see a very nice scar quality, especially in that area in the fold. But they say about a 4% risk of a poor or unfavorable scar forming from your surgical incision. If you are undergoing a lift at the same time as your breast augmentation surgery, then substantially more scar is created on the breast. And so there's more risk of having an area of the scar that's widened or thickened or needs some sort of laser resurfacing or surgical revision to make it look better. I would say as high as 30% risk for doing a simultaneous augmentation mastopexy needing some sort of scar revision work. Fluid collection formation or a seroma forming after breast augmentation, low risk, about 2%. Risk of an inability to breastfeed. Usually that is a rare complication. They say in up to 1.6% of patients. I personally think that's a little bit of a low estimate on breastfeeding difficulty, as I know lots of women who have never had breast surgery and had a really hard time breastfeeding. So that's always a little bit of a wild card for people. Chronic pain is something that they don't put a percentage risk on, but it's a known possible risk. I think as long as you're choosing an implant that is an appropriate size for your body and not overstretching your tissues, that there's a very low risk of chronic pain after having breast implants placed. The next 2 paragraphs get into what I refer to as rare risks associated with breast implants. First, it talks about breast implant associated anaplastic large cell lymphoma. We refer to this as BIALCL. So this is a lymphoma, a rare type of blood cancer. This has been linked almost exclusively with cases where patients had a textured breast implant at some point in time. This condition is the reason why the FDA recalled the Allergan textured breast implants back around 2019. So this implant has a rough surface on it, and it's shaped like a teardrop, which is great because it's got a natural shape, but if it rotates in position, it looks really bizarre. So they made a rough surface on these to try to help kind of Velcro them into position so they would not rotate. Smooth shelled implants have a different surface to them. We have not seen the same risk play out of breast implant associated anaplastic large cell lymphoma with smooth shelled implants compared to textured shelled implants. Currently at the moment, that's why I'm usually recommending a smooth shelled implant. This is something that's always sort of changing with technology, and as new implants come onto the market, it's always worth talking about these risks and look at the research that's been done for each implant before you decide which one you think is right for your body. The next paragraph is called systemic symptoms. I really wish, and that's probably backwards for you guys to see, but I really wish they would have just called this paragraph breast implant illness, because that's what it comes down to. So we acknowledge that some women feel that their breast implants are making them sick, giving them any number of health problems like joint pain or hair loss or skin rashes, chronic fatigue, GI upset, muscle pain. There's a list of over 100 symptoms that can be associated with breast implant illness. What we don't yet understand is why some women can walk around with breast implants in their bodies for decades without having any issues, but other women would have this condition arise. But we do want patients to know that if you get breast implants and you feel like they're making your overall quality of health worse or you're having health problems because of them, we want to know about it. We want to take this seriously. We want to work with your primary care doctor to work this up and make sure we're not missing something else going on. There's no specific test we can give patients that says, yeah, you've got breast implant illness and you know you were just going to have a bum thyroid someday. But if we can rule out any other conditions going on, then sometimes the treatment is, hey, take the breast implants out and follow you for 2 years and see if these symptoms get better or not. There is some suspicion that the immune system could be driving these symptoms. And just like some of us could eat peanuts all day, but other people might be so highly allergic, their airway swells shut if they have a peanut, everybody reacts differently to different substances. So unless you have a history of an autoimmune disorder, I don't think you would be at high risk for breast implant illness, but it's something worth talking about before surgery. This last section that I'll refer to goes through what I think of as device-related complications. So the first is capsular contracture. Any foreign object we put in the human body will heal with scar tissue around it. And as long as that scar tissue stays thin and soft, it's never an issue. It's normal. But if that scar tissue got thick and tight, that is a capsular contracture. It can make the implant feel hard. It can make it look funny, sit in a weird position, sit too high. It can make it uncomfortable. It can cause pain against the chest wall. So that's a capsular contracture. The Mentor Corporation estimates the risk of a capsular contracture is as high as 36.9% of patients within 10 years of surgery. Now that's drawn from looking at studies that included reconstructive patients as well as cosmetic patients. In our practice, I think we see more of a 2 to 3% risk of a capsular contracture within a decade after surgery. We think that surgical technique can help prevent capsular contracture. We make sure the pocket is very clean before we insert the implant. We're handling the implant very carefully, placing it into the pocket, using a funnel to squeeze it into place without unnecessarily handling the implant. I think that going under the muscle is protective against capsular contracture also. So I think that there are measures we can do technically to try to prevent this from being a complication. That being said, it's still something that can pop up for patients years down the road from surgery without a good explanation for why it's happened. So it's a risk to keep in the back of your mind. It can require more surgery to take out that thickened scar capsule. If it happens once, you're also always at more risk of it happening again in the future. And so it's a reason why some patients are having things like a biologic mesh placed into their breast with a revision surgery to try to prevent it from coming back. Other risks that go with breast implants: leak and rupture. So I tell patients these implants are tough. We play with these sizers in our consult room all day long, every weekday. But over time, these can fail. It could be related to a trauma. It could be a car accident trauma to the breast, or it could just be wear and tear, normal, they call crease fold failure, where there's a small crease in the implant with friction that over time just leads to a breakdown. So currently, they estimate, or at least the Mentor Corporation estimates, that their 10-year leak rupture rate is as high as 43.9% of patients. Again, this is different depending on what data you look at from what study. The FDA told them to put their worst numbers in these documents. We think we see more of an 8 to 10% risk of leak rupture within 10 years after surgery. So if a leak or a rupture event does happen with your breast implant, it is not a surgical emergency. You don't have to be rushed into the operating room to change out your breast implant. It's something that we would just want to, in the near future, change this out because we know it's not working the way it's designed to. And so they used to have sort of this going advice on the street was, we'll change out your breast implants every 10 years to prevent leak or rupture. That is no longer the FDA recommendation. There may be certain surgeons on Instagram who are still recommending that. Technically, here's what the FDA recommends. There's a paragraph called recommended follow-up right here about it. They say, even if you're doing awesome, your breasts are doing great, you've got no problems, no symptoms, and everything looks amazing, you should still get an ultrasound or an MRI of your breast implants starting 5 to 6 years after they're placed, and then every 2 to 3 years after that to monitor for any signs of leak or rupture of the breast implant. If those studies suggest there's leak or rupture going on, that would be the reason to change out the breast implant. I tell patients that mammograms do give us little looks at the breast implant, but it's not the most sensitive or specific study to detect a breast implant leak or rupture. However, I have had patients come in where a mammogram did pick up a leak or a rupture. Again, not a surgical emergency. This is not a toxic event for your body. Modern silicone gel is very thick. It doesn't drain into the tissue around it. It just sags in place. We would just say, hey, let's pick a date in the near future to get this thing changed out. If you happen to have saline implants and you have a leak or a rupture, you get what is often referred to as a flat tire, where the implant just deflates, your body resorbs the saline, and you would notice the difference and say, okay, it's time to get that changed out and addressed. Personally, what I don't like about saline implants is that they tend to be more ripply, sloshy, and heavy compared to silicone gel breast implants. And I think the silicone gel feels more natural, overall looks better and performs better over time too. All right, other risks that go with breast augmentation and the breast implants. Things like visible rippling of an implant through thin tissue. Again, this is a reason why I like to go under muscle to get at least the top 2/3 of the implant covered a little bit thicker. But for extremely thin tissued patients, you could see a little edge of the implant or a ripple. If that is your personal situation of having extremely thin tissue, sometimes we do talk about tissue support with a surgical mesh or a biologic mesh. That's something that we can address during the consultation. Another risk is that over time implants can shift in position, or maybe an implant stays too high for too long. Implants can slide towards the armpits over time. One can slide too low. Those are all malposition issues, and those are reasons why some women have breast augmentation revision surgeries in the future. I think that covers the highlights of all the fun facts you never wanted to know about breast implants. The other things that I didn't talk about yet are just that breast implants come in a variety of sizes, and that's commonly referred to as the CCs. So are we talking about a small implant that's like 175 cc's or 200 cc's? Are we talking about a bigger implant that's somewhere 450 cc's or bigger? We talk in cc's usually to discuss overall volume or size of the implant. And the other factor we talk about is the profile, which is the height versus the width of the breast implant. So profiles have names like moderate classic or a wider, flatter implant versus a high profile implant, which is narrower and taller. I say think of it like houses. The moderate classics like a sprawling ranch in the country, and the high profile implants like a tall, skinny townhouse. They may hold the same amount of furniture, they're just doing it in a different configuration. So that's something else to talk about during your consult. If you've got certain inspiration photos to share of what you're trying to achieve, or if there's a certain profile that you know you feel drawn to more than another, that's definitely something to point out and talk about with your surgeon. Hopefully that gives you guys some food for thought and fun facts about breast implants. Thanks so much for listening to this.